Good afternoon, everybody. On behalf of the West Virginia Clinical and Translational Science Institute, I want to welcome you to our fourth installment of our Clinical Quality Improvement series. Dr. Greg Barretto was really integral in planning and implementing this series, and he's been a great supporter for us. He kicked off the series with the first two segments as well, and so I'm actually going to call Dr. Barretto up here to introduce our speaker today.
All right, good afternoon. So, Dr. Greg Ogrinc is a general internist at the White River Junction VA Hospital in White River Junction, Vermont. He is the Associate Chief of Staff for Education and the Senior Scholar for the White River Junction VA Quality Scholars Fellowship. At the Geisel School of Medicine at Dartmouth, he is the Director of the Office of Health Systems and Clinical Improvement and an Associate Professor of Community and Family Medicine and of Medicine. Dr. Ogrinc graduated from Case Western Reserve University School of Medicine in 1997 and completed his residency in internal medicine at Metro Health Medical Center in Cleveland. He also completed the VA National Quality Scholars Program at the White River Junction VA and his Master's of Science in Clinical Evaluative Sciences from Geisel in 2002. Dr. Ogrinc is the director of the Quality Literature Program at Dartmouth, which developed the Standards of Quality Improvement Reporting Excellence, or the SQUIRE guidelines, a standard structure for sharing improvement work through published literature. Dr. Ogrinc is a leader in the field of quality improvement reporting, and we are honored to have him spend the day with us, meeting with individuals in our QI programs, providing the seminar, and a focus work group this afternoon for a group of 22 clinicians and research coordinators. So please help me welcome Dr. Ogrinc.
Thank you for the introduction. Good afternoon. It's great to be here. Thank you to Dr. Lockman for the invitation to join you as part of the boot camp series. I feel like the room is skewed this way, so I'm going to move over. I'm sorry, guys. I'm going to move over to this aisle since this is where most of folks are standing. I forgot my clicker. So what we're going to talk about over the next 40 or 45 minutes is my prepared comments, is this idea of the challenges and joys of publishing quality improvement work with a focus on these standards for quality improvement reporting excellence guidelines. So those are the SQUIRE guidelines, and I talk a lot about SQUIRE, so I'll use that a lot. And it really gets into that idea of the scholarly and academic aspects of doing QI and reporting about it. So there are four objectives I will cover in this in the presentation. First is to be able, so you should be able to recognize the challenges in reporting quality improvement in the literature. These are real. It's difficult to know what to put in a written article. It's difficult when you read articles to see what's in there. Describe how to use SQUIRE to achieve greater success. So why might these be helpful? How are you going to use them? Why might you want to use them? Describe how context can be described in QI publications. We're going to touch on this in this next hour. It's kind of threaded through the presentation. Those of you who come to the workshop this afternoon, we're going to dive into context in a lot more detail. And then lastly is compare and contrast clinical research with human subjects and quality improvement. This is sort of a thorn in the side of folks who do improvement and IRBs. I know as your last presentation in this series, we really focused on this, and I'm going to give just a kind of make a connection to that and show how the SQUIRE guidelines might be helpful as you struggle with, as many of us struggle with that distinction. So let's start with a story, and this is a story is sort of, I think, rather well known. This is an article from New England Journal. It's by Peter Pronovost and his colleagues. And the title here is An Intervention to Decrease Catheter-Related Bloodstream Infections in the ICU. And I would draw your attention to the date here in 2006. This intervention was not a fancy new antibiotic impregnated catheter. This was actually an intervention that was a checklist. This is the article that really spawned a lot of the interest in that checklists really work. And the checklist was 5 simple things. It was Don't use the femoral site, so use the internal jugular, the subclavian site. Wash your hands, cleanse your hands before you put in a catheter. Use full barrier protection. Use chlorhexidine as the skin prep, and take the catheter out as soon as it's not needed. So these were not sort of fancy interventions. But let's take a look at their data and what they present in the article. This is their table 1, sort of your standard table 1 in an article. The periods here are the periods of when the intervention was rolled out in different ICUs. The number of catheter days per month is the way they measured the exposure. So if I was a patient, I had a catheter in for 5 days, I would contribute 5 catheter days for that month for that amount of data. And then they describe it by teaching hospital and the number of beds. So you get some breakdown and some understanding of the types of hospitals that they use. This occurred in Michigan, so sometimes this is referred to as the Michigan study. It's also referred to as the Keystone study, because it was the Keystone group in Michigan that helped enroll all the ICUs. This is their baseline data. The baseline data, 55 hospitals contributed baseline data for this. There were 2 infections. Here you see the median number of catheter days in an interquartile range. And you see the number of infections per 1,000 catheter days. So this is important because this is their main outcome measure, how they standardize that number. So infections are not common, but when they're common, they're serious. And so by making it out of 1,000 catheter days, it's a way to normalize the data. And sort of as you look at teaching status or you look at the size of the hospital, the baseline sort of, no matter how you slice it, it's all very similar. So how about their outcomes? And these are really spectacular outcomes. They did great work here. So you see the baseline outcome, 2.7. So this is the same as 2.7 we saw on the previous slide. And as you look at the overall number during the implementation and over time, the median went to 0. There were still some infections that were occurring, but the median went to 0. Really nice results. Really good evidence that, boy, this intervention worked and was effective. And if you look at teaching hospital or non-teaching, everybody eventually got to a median of 0. The academic teaching hospitals took a little bit longer time to get there, so maybe there's another story there about the uptake of stuff in academic centers. But when you read the article, you're left with a couple of questions. You would say, well, what actually happened with this work? And how can I get these results in my ICU? Can I get these results? And it's actually very difficult to tell from the way the article is written. So there's a series of other articles that followed this. So Pronovost and his group didn't stop there. They actually kept looking at it. And in 2009, so this is now 3 years after the initial article, this is actually the same year Atul Gawande's book came out, the Checklist Manifesto, which really heralded checklists as being the answer for many issues in healthcare. This was in Lancet. Pronovost is one of the other authors, as well as Charles Bosk. And this was not a lead research article. It was an area called Perspectives. But what they said is that the Keystone study, the story was oversimplified. And they lament the fact that checklists have not penetrated medicine. They say, well, this is really cultural and social. That a technical solution, the checklist, was used to solve an adaptive, a socio-cultural problem. So when I present this to medical students and residents, they kind of look at me and they say, well, I went into medicine to do science, not to solve socio-cultural problems. This doesn't make sense to me. But this is actually what they found as they looked at this something as simple as a checklist. They said, you know, there's some things we didn't really highlight in that article. There's leadership for administration and improvement training for staff, valid and sound measurement of infections. And if you ever hear Peter Pronovost talk or you had a chance to speak with him, he is passionate about getting that measurement correct before you start making changes to the system, so you know whether a change leads to an improvement or not. Feedback from all frontline health professionals. And how about this one? Well, there were actually more than 100 Keystone checklists, not just one. Each site modified it for local use. Now what happens if you try to apply, you submit your article to the New England Journal and you say, well, we didn't really have one intervention, we kind of had 100 and everybody kind of changed it. So the reality of what was happening with the checklist is not captured in that initial article. As I said, no, they actually didn't stop in 2009. In 2011, Charles Bosk and Peter Pronovost and Mary Dixon-Woods wrote this article. Now, Mary Dixon-Woods is a sociologist from the University of Leicester in the UK. And so she said, explaining Michigan, developing an ex post theory of a quality improvement program. This is a really long article, really dives into kind of the sociological approach to understanding what happened. And the goal was to develop and evaluate interventional programs. They say QI studies are really poor at describing exactly what a program comprises. And they said Michigan was successful not just by taking a checklist and handing it to people and sort of walking away, but it generated, and look at the words they use in the article, it generated pressure to join the densely networked community. It reframed it as a problem. Interventions that shaped a culture harnessed data as a disciplinary force. That sounds a little extreme, but so they said in hard edges, the checklist itself, activist tactics and the data. What this actually brings up for me is the real work that was happening at each of those ICUs was really difficult. People worked really hard in making that checklist work at their individual sites. So when you look at this, the Pronovost work was funded in 2003. It was published first in 2006 and then 2009, and then late in 2011, another article. 8 years from when they started, 5 years from the initial article, they're still trying to explain what happened with a checklist. Interesting. So I think this actually brings up a problem in the QI literature. And the problem is that we don't describe the interventions very well. And this is a problem if you're not reporting. And this isn't a unique list of issues. This is the same list of issues when you don't publish your research results. Well, you don't advance science, and you slows dissemination of interventions, and you may have redundant, unnecessary work, and it really limits learning from mistakes. And we sort of know why QI isn't published more often. It's often done by frontline individuals. They don't have incentives for publishing. They're concerned with local change, with making things better. Well, editors and peer reviewers are unfamiliar. They're still skeptical about what exactly does this mean? This doesn't fit my paradigm of research. And writing about QI is hard. It is. It's difficult. And it's hard because it's not the same as drugs, tests, and clinical procedures. It's about change and experiential learning. It's very context dependent about what does it really take to move change into your specific setting. Interventions are complex, change is fragile, and this is that idea of 100 different keystone checklists. They're adapted, they evolve, they're reflexive. We do this all the time. But how do you capture that in written literature? And so the result is there's uncertainty about exactly what you should include. So in 2005, there was published a draft set of guidelines for writing about improvement. And then there was a period of open public discourse. They were published in BMJ Quality and Safety. It's one of the BMJ specialty journals. And not all the feedback was sort of bells and whistles heralding this new thing. One of the editorials written by Peter Pronovost was draft guidelines for quality improvement. 2 steps forward, 3 steps back. So they took a hard look at these draft guidelines. Now they eventually were changed and modified, and what they became were the SQUIRE guidelines. And SQUIRE guidelines currently live, like most things now, they live on a website. So the website is squire-statement.org. This is what they look like. In the center of the guidelines, you can click to get to an area here. They're available in a PDF, and they're also available in some translations in Japanese and Spanish and Norwegian, I think. But what do they actually look like? So this is what they look like. And I'm not going to walk through all of these. There are 19 different items. You can peruse them on your own. Those who come to the workshop this afternoon, you're going to get to know some of these items intimately. But it's things like what should go in the title? How do you organize your abstract? What about background knowledge? What about the local problem that you're starting to describe? And the advantage of the website, if you click on this point here about background knowledge, it takes you to a page called the Explanation and Elaboration section. Still has the item here, and then there's an example. It's a pre-2008 example. Then underneath there's an explanation why we felt that was a good example. So we're actually in the process of revising the SQUIRE guidelines, which I'll talk about more in a minute. So that's why the examples here are still 2008, because we're sort of in the process of actively doing that. So this structure exists for each of those items. I think it can be very helpful for you as you're looking to structure a paper. If you continue on the website, there's a section of resources. There are a couple of example manuscripts, and then there's a table about journals. So if you do some work in QI and you want to figure out where I might be able to present it, this is one place you can look. So all right, so that's where it is, and that's where it lives. As I said, I'm not going to go through each item. That's something you can kind of do on your own. But how does this help? Well, it's a set of publication guidelines for reporting QI. Interestingly enough, it's a checklist format. It's modeled on other guidelines. So Consort is probably the best known set of guidelines. It's the Consolidated Statement something randomized trial. I forget what they all stand for. If you do a randomized trial, every journal is going to expect that you write it in the Consort structure. So that was the first set of guidelines, came out in the mid to late 90s. And since then, there are guidelines for observational studies, diagnostic studies, and I think there are close to 100 different sets of guidelines. So SQUIRE is one of those types. And the immediate purpose is to do exactly what we saw from that article. Well, increase the completeness, precision of published reports, to encourage more and better reports, and certainly the audiences, as you would expect, authors, reviewers, editors, users, improvers, funders. So all of that is a chance to kind of help move the field forward. So what does SQUIRE do and what doesn't it do? Well, it offers guidance on these original studies. It's context dependent, complexity and reflexiveness. Has a familiar format, so it's introduction, methods, results, and discussion. So that's very familiar to us as we read journal articles. But it's this balance between measuring the impact and discovery plus an explanation of the mechanisms that made it happen and made it work. A lot of things that SQUIRE doesn't do, or certainly wasn't intended to do. It's not intended to apply to editorials or reviews. Doesn't demand rigid or mechanical use. This was interesting because once our website went up, I received an email from a woman in Australia who was working on her PhD, and she said, I think I've used SQUIRE to write my PhD thesis. What do you think? And she actually sent me a Word document where she took a table of SQUIRE guidelines, added a column, and kind of used it as a fill in the blank. And it's like, well, that's actually not the right way to write a paper. And so it's not intended. It doesn't sort of, like I said, it's not a fill in the blank. Doesn't tell you who the audience should be, the readership or journals. And this is my favorite quote down here. This is from Frank Davidoff, who's part of our SQUIRE leadership team. It doesn't clean up a messy room, but it turns on the light so you can see what needs cleaning. So if you do poor quality QI work, or you do kind of a real nice, focused, simple little project, which is really important QI work, you don't sort of run it through SQUIRE and then it's like, oh great, now it's ready to go to JAMA or New England. It's like, but it helps you focus on what can make your QI work better and what should be in the written report. So that's your introduction to SQUIRE. One of the things I've realized if I talk about improvement and quality improvement is that it often means different things to different people. And sometimes you talk to people and they say, I just don't get it. There's QI, there's TQM, there's CQI. My residents are supposed to do PBLI, practice-based learning and improvement, and systems-based practice. Like, are they the same? Are they different? What about patient safety? Well, I know what that is. That's really just an offshoot of health services research. And so I think it can be very confusing. So I'd like to share with you and think about and try to share with you how I think about what is quality improvement and how can you define it. It's a little bit of a step up, kind of a higher level view, but I think it helps for me to think about all of these different activities that often fit under the quality improvement title. So two models here. What I'd share with you is this idea of evidence-based improvement. So what we want for our patients is some kind of measured performance improvement. And where we start is with generalizable scientific evidence. And we have a hope and a thought that if we apply this to each particular patient, we can get to better patient outcomes. Now we know this isn't true because when we look at published literature and things that we know to be the right thing to do, there's a huge lag, 10, 12, 15 years between when we know something is the right thing to do and when it actually happens in practice. So this is important. We'll never stop doing this. This is how we learn as physicians and nurses. You learn to take care of individual patients. That's not going to go away. But if you think of if you change this equation to a particular context, you actually get a very different equation. And you can start to pick out and identify 5 different domains of knowledge that need to come together to make this happen. So this is after some work by Paul Batalden and Frank Davidoff from 2007. So let me show you these different domains of knowledge. I'm going to start over here. This is where we're most comfortable. Generalizable scientific evidence, right? You control for the context-free knowledge. You want to build knowledge that's generalizable across different settings. You use certain experimental design and statistics to do that. Is there a p-value? Was this really effective? But once you start talking about applying evidence into a context, your outcomes become very different. So it's not just what happened clinically to the patient, but you start talking about satisfaction. And what about staff satisfaction? What about functional status of patients? And then it also brings in the idea of costs. So this has been an important focus, I think, on the value of care that we deliver. And how does the quality and the cost come together? So you might know the right thing to do, but you have to know something about the system particularities. What are the structures, processes, and patterns? What about culture in the context of changes? So I'm a VA doc. If I'm trying to make evidence work at the VA, that's very different than it happening over across the river at Dartmouth Hitchcock Medical Center. We have different staffs. We have different electronic medical records. All of that fits into it. You might have the data, you might know where you're putting it in, but you have to choose the plan and make them come together. And that's also not easy to do. And then you have to execute the plan. You talk about change management and sustaining change and things like that. And when you think of knowledge domains, well, all right, this one is pretty easy to define. We're pretty good at this. These are places where we don't have as much knowledge about what to do, particularly in healthcare. You talk to some of our business colleagues, they have a better idea of how you execute and manage change. But we're less good at that in healthcare, particularly those of us who are clinicians, I think, at the front lines of care. But all of this needs to come together. Now, I think another way to think of this that is often helpful, I think particularly for residents and medical students and physicians, is this way. It's thinking of between this idea of what do we do with individual patients versus the system of care. It's not really versus, it's really individual care and the system of care. So with individual patients, you do an initial workup with history, physical exam, you get some labs, an ultrasound or functional test. You might have watchful waiting, maybe surgery, maybe medications. And you really do the same thing in the system. You have some experience, there's ways to work up the system and think about it with data and process modeling, and then you use something to make changes in the system. It might be PDSA, it might be the root cause analysis, who knows, lots of different ways to do that. The advantage is that when you start looking at it this way, this is really the essence of quality improvement. And this is really what you end up doing whether you're using Lean or Six Sigma or any of those different change programs. They all have very similar structures and things that are used. Now what I like about that article where that evidence-based improvement formula came from is that it also gives a definition. And this is my favorite definition of improvement. So let me read it to you. It's the combined and unceasing efforts of everyone, healthcare professionals, patients, families, researchers, to make changes that lead to better patient outcome, better system performance, and better professional development. Okay, so that's kind of a high-level thing. It has these 3 outcomes of patient outcome, system performance, professional development. So I'm a visual person, so I like this. It lends itself to a diagram. You can take these three outcomes and sort of put them in a triangle. We often refer to this as the triangle diagram as you're thinking about improvement. The real strength of this, though, is in the center, when you put everyone in the center. So, and this is one thing I think is different about this definition. So if you go up to somebody and say, well, do you do quality improvement at your hospital? They say, oh, yes, we do. I say, well, how do you know? I say, every day I go to lunch and I walk past a door and it says quality improvement. And I know in that office they're doing quality improvement. Oh, you say, oh, the medicine department just hired a vice chair for quality. I'm so glad she's going to take care of quality for the department. This definition and this model says that, that's actually no longer acceptable. This is a shared responsibility for all of us who work in delivering health care. Now this is perhaps a kind of a simple diagram, but what I like about it is you can start pushing into it and you can start asking questions at different points of this diagram. So you can say, well, population outcomes, what about measures and variation and causes and system performance, talk about reliability and failure within our systems and certain standards, and professional development, this whole idea of competence and in resident training and cooperation of professionals, and are you even allowed to talk about joy and pride in work anymore as healthcare professionals? Sometimes it feels like it's seeping out of the work we do as healthcare professionals. Well, everyone, you actually changes probably how you're hiring and orienting, supervising, what you recognize. You can see connections between leadership and review and recognition, and even connections between the system performance and professional development of governance and financing. So what starts, I think, as really a nice, for me, a simple way of thinking about all these elements of improvement actually has quite a bit of depth to it. And you can start to see where certain parts and these different elements of QI that we often think of and that people are part of fit into it. So this is my view of how I think about improvement work. This is not going away. And we know this because of the changing educational expectations of our learners. In 1999 to 2003, the ACGME had the 6 general competencies for residency training and fellows. Practice-based learning and improvement, systems-based practice. These are the 2 that still give program directors the most heartburn about how they're going to teach them. In 2006, I think, we had the Health Professions Education report from the IOM. Apply quality improvement was one of their recommendations. I'm a physician, but my colleagues in nursing, the quality and safety education for nursing, started in 2006. Same requirement for all nursing training, LPN, RN, BSN, NP, DNP, PhD nurses. They all are under this umbrella of learning this as part of their professional development. Same with pharmacy training, health administration training, dentistry, on and on as you go through all of the health professions. American Board of Medical Specialties. Anyone who is recertified in the past couple of years, I did in 2010 in general internal medicine, I had to send in data from my patients to show that, yep, I'm looking at it and I'm doing something to make care better in a systematic way for my patients. So it's part of your professional development as a physician. And most recently, the AAMC, which is the Association of American Medical Colleges, had a Teaching for Quality report from January of 2014 to integrate this across the continuum, expect faculty to be competent and aligned to produce good patient outcomes. This was January of 2013, so it was almost a year ago. There's no shortage of requirements from accrediting organizations for our learners and for our practicing physicians. So there's going to be building and growing interest in doing QI, and academic centers need to figure out how to do this, I think, in a rigorous and thoughtful way, and to be able to publish it and share it and do that in a way that sort of leads the field of what's happening. The SQUIRE guidelines helped to address this in 2008, but we also realized they were incomplete. And they were a first draft. We call them SQUIRE 1.0 now, because we're actually moving towards SQUIRE 2.0. So as the field changes, where we're headed is thinking about improvement as a hybrid of social science and clinical research approaches, so developing these different methods. Published work needs to be sorted by theories and models, so improving the structure of what happens with QI work, and this increasing challenge of distinguishing improvement from research. So what have we done as we're trying to upgrade SQUIRE and moving towards 2.0? We're right in the middle. This work is funded by the Robert Wood Johnson Foundation in New Jersey and the Help Foundation in the UK. What we started out was by evaluating SQUIRE 1.0. So I'm going to share with you some of what we learned from talking to users of SQUIRE 1.0. We talked to over 30 individuals from around the world, US, Canada, UK, and Sweden and Norway. So US and North America and Europe. And this is what we asked them. What was confusing? How did it help? What could be better? And these were focus groups when feasible, did a lot of things on Skype and also semi-structured interviews. Asked graduates who had used SQUIRE as part of graduate learning programs, faculty of the programs, authors, both academic and non-academic, and then editors and QI program leaders. So we tried to talk to a wide range of individuals. There are three things we learned. These were things we hadn't even hypothesized. So the first was that experience doing QI and research in general affects the impressions of clarity and usability of SQUIRE as a set of guidelines. There's a relationship between more experience and those who were said, you know, this is more clear to me. And what I'll do is this was qualitative research led by my colleague Louise Davies, but let me share with you some of what we found. This is a Masters of Science advisor from Sweden who was mentoring students using SQUIRE. And what she said was the doctors I was advising as a faculty person, they only knew statistics and quantitative work. They were only familiar with context-free research. I explained to them it's like writing up trial results and then the experience of running that trial. So kind of that dual component of sort of how she experienced it and how she was helping those who were more novice. This is someone who has more experience. This is someone from, an individual from Norway who had quite a bit of experience in writing about improvement and writing about research. Said, you know, much of the guidelines is common sense. It's a transplantation of research methods into QI, making sure your QI project is written up as rigorously as research. Someone else said this, I whined to my advisor about that problem. The document you create at the end if you use SQUIRE is unintelligible. Or like our person from Australia I was mentioning. But the problem is I use it to write my first paper. Well, this seems simple to me now. Obviously, you don't have to put it all in there if it doesn't apply. So again, the process of writing, and the more writing you do, the more intelligible things, guidelines like SQUIRE or Consort or any of those are for you. Second point, SQUIRE helps you plan. It does not help you write, per se. This was fascinating because honestly, guidelines are not intended to help you plan. They're intended to help you write. But people said, you know, we use SQUIRE a lot for planning. We complete the sections up through methods at the time we design the study. But SQUIRE creates long reports if followed exactly. Another person said, the guidelines tell me everything, but they don't tell me what's important to include. There's no hierarchy. So you begin to see the impact of experience. This happens to anyone when you write a paper. You have to decide what to include, what not to include. Last point. There's disagreement and confusion about what parts of the work of QI should be reported. And this was frustrating for us. SQUIRE didn't seem to help with this. Said, well, that experience of getting all that work, the buy-in from the participants, it may have been a useful paper in and of itself. But not of interest to the sorts of journals and the caliber of journals that I would publish the results in. But when I give talks, this is what people ask me about. So those of you who have given presentations, you always have your nice 10-minute podium presentation, and then somebody comes up to you afterwards and says, all right, this was really good, really what actually happened? And so the SQUIRE is trying to help get at that. What was happening at all those different sites with the checklists and the Pronovost work? When I was trying to write, the important things you can't really write about. For me, it was about, what was really important was how I thought about the project was and what the intervention would be and how it failed because it wasn't relevant to the people who were supposed to do the intervention. How do you write about that? It's an important part of QI work. Not everything you do works. There's lots of failures along the way. And how do you capture that in a way that is helpful for the people reading your article so that they don't make the same mistakes? So how does this help us and what's likely to come in SQUIRE 2.0? Well, an emphasis on the inclusion of clear explanations about why the improvement should work. So the mechanism, the theoretical framework. When you do research, you have to have a theoretical framework for your work. We're not very good about doing that in QI. Emphasis on explicit description of context throughout the paper. So currently context is kind of weaved throughout SQUIRE. Context now has its own section. And then a clear direction about including iterative changes to an intervention and those failed parts when relevant. An expectation that you have to capture those things that didn't work. So this is a little sneak preview of SQUIRE 1. We're currently at 1.6. We have over 70 individuals from the US, Canada, and Europe who are sending us writing samples using version 1.6 and then giving feedback about using those writing samples. What you see, if you've looked at the regular SQUIRE guidelines, these are more concise. They are more focused. Calls out context here. We have things about logic models and the mechanisms that were not part of the initial SQUIRE guidelines. So the workshop participants this afternoon, we're going to give you lots of time to look at all of SQUIRE 1.6 and to offer some feedback and compare and contrast to SQUIRE 1.0. So last topic I'll cover is this issue of QI research and how you distinguish. This is a challenge for many, for improvers and researchers and IRBs, and I think for patients and families and those who are the subjects of the work that we do. And the question I like is not just is this QI or is this, but what's needed to address ethics of QI and research. So research ethics are fairly easily situated within the IRB about protection of human subjects. Our committee at Dartmouth is called the Committee for the Protection of Human Subjects. But what about the ethics of QI? Are they the same as research ethics? Are they the same as clinical ethics? Business organizational ethics? Probably a nexus of many of those. And in the Annals of Internal Medicine 2006, they put forward a framework for QI ethics. And one of the things they recommended was that an independent review of QI work. There's a challenge because IRBs don't always understand. They're focused on research, so the intent and the methods and the analysis of QI work. So we had a hypothesis that now we have publication guidelines, maybe SQUIRE would help IRBs understand this. And so we set out to develop a practical instrument for IRBs, researchers, improvers, to differentiate between QI and clinical research. Now, there are lots of institutions that have these kind of checklists, so this is, I don't think, anything all that unique, other than the fact, when I show you pieces of it, other than the fact of how we structured what is QI. So it's not necessarily an instrument of exclusion. This is where we started. We actually started, the group that worked on this was myself and a bioethicist at Dartmouth, the head of our IRB and one of the staff members from the IRB. And we started with this idea of the continuum of care and investigation. So everything from direct one-on-one patient care over to research. And the point made by Lewins in this article cited at the bottom is that quality improvement is closer to the therapeutic relationship that happens with one-to-one patient care than it is to research. Let me give you some examples and try to flesh that out. So here's an example. We'll use an example of a patient having an MI. Patient receives a cardiac catheterization. The balloon is inflated within 82 minutes of arriving at the ED. The goal is 90 minutes door to balloon time, and we say, great, Mr. Johnson received reasonable, good care based on what our goal is. Great, that's direct patient care. Well, the other end of the spectrum is also fairly easy to understand. It's, a randomized trial of a new medication for acute MI. Great, so that's easy. Well, you start to do a retrospective cohort analysis of current cardiac cath and current medical therapy. Certainly still research, but maybe a little bit closer, looking at practice patterns and things like that. But what about this, the muddle in the middle? This is what gets people confused. But what if you have a medical center making changes to improve the efficiency of door-to-balloon time for acute MI? This is actually much closer to impacting the care Mr. Johnson receives. It's actually very close to that therapeutic relationship between the health system and what the patient receives. But what about something like this? Very similar to what we heard about from Pronavost's work. A study of a checklist for cardiac catheterization where sites are randomized to using the checklist, or it's rolled out sequentially over time. Well, this probably is QI work with an element of research as part of it. And it's this area here, I think, causes the most confusion for folks, because you're not really quite sure where things sit. So what did we do? We started in spring of 2009 after the SQUIRE guidelines were published. We had initial checklist that was drafted, started with our IRB director. We had an expert panel of folks, of researchers, the director of research at our VA hospital, and we had face-to-face, and we kind of developed this over time. We applied it to historical submissions, and the IRB picked out submissions that were particularly troublesome, where they spent a lot of time trying to figure out what this is. And then we went back, we revised the instrument some more. And then we used it prospectively with submissions to our R&D committee at the VA. And since 2012, we continued local testing. We've published the development of this tool in IRB journal. And our plan for formal psychometric testing, well, that's still on hold because we've been stymied. We haven't been able to get funding. This development work was unfunded work, and we're looking for funding for more work. So let me share with you what it is. This is the reference for those of you who might be interested from IRB Ethics and Human Research from last fall. There are three columns. There's an attribute, there's quality improvement column. This column is taken from the SQUIRE guidelines, and it's explicitly intended to demonstrate what is quality improvement. So it's not just a diagnosis of exclusion per se. And then this is clinical research with human subjects, and this column was taken from the federal definition of clinical research. So there are 6 attributes. Intent and background methods are the first 2, and you see things like, well, this is really a specific performance gap. Well, this is developing or advancing existing knowledge. Methods. I'm surprised that sometimes people still say, well, if you're collecting and using data, that must be research. Well, that's actually not true. QI uses research all the time. And so how you use that, statistical process control or other methods, we're really looking at things happening over time, where here you're generating hypotheses or you're comparing groups or identifying factors between groups. The intended benefit in improvement is often immediate. So we're trying to work on our door-to-balloon time. We actually expect the next patient who comes in to have a better door-to-balloon time than the last patient if we're working on that as a QI project. That may or may not be true with research. And then the risk in QI is often to confidentiality. If you have high risk, if there's emotional, psychological, physical, financial risks, it probably belongs, it's probably an element of research, and the IRB should probably be involved. Applicability of results is often immediate and reflexive, and here analysis is often delayed or periodic. Now, we're talking about publishing QI, so part of my favorite row here is actually this one, sharing and disseminating of results. So system-level outcomes, processes, refinement of the intervention, context may be shared through peer-reviewed publication and presentation outside the institution. So that's actually a really key point of this, is that just because you intend to publish or want to publish doesn't make it research. Now, in research, certainly it's expected that results will be published in there. If you have any tick marks in that right-hand column, it has some element of research, and the IRB should probably look at it. But we're comfortable with our IRB and our processes that if you only have tick marks here on the left-hand column, that this is really QI work and you can proceed. Now, just because it's QI work doesn't mean it's an ethics-free zone. So that's actually important because sometimes we think, well, it's QI work, just go and do whatever you want to do because it's QI and just don't even tell me about it. Institutions and organizations still need to develop a way to oversee quality improvement work because there can be waste of resources, there can be harm to patients with people if there isn't some oversight. But I think the concern here is the IRB the right place to provide that oversight? Probably not, because most IRBs are fully busy overseeing research work. So, just by way of summary, covered lots of different topics, but writing about QI is challenging. But these guidelines like SQUIRE, I think, can help you be more successful. Quality improvement, however you define it, whatever umbrella you put it under, is only going to be increasing. We know that from the, I think, the accreditation structure and the oversight structure. And so the intent to share results are also going to be increasing. And then lastly, I think clearly distinguishing between QI and research. And the checklist I shared is not an absolute adjudicator. One of the things we found with it that was most helpful is it helps the conversation between the IRB and those who are submitting it. So it's not, so you don't just sort of use it, again, it's not a checklist you give and walk away from, but it's something, it helps the conversation about what it is you're planning to do. So that's all I have for you for prepared comments. Let me stop there, and I'll be happy to take any questions in the last 10 minutes.
For your QI work, are you actually creating a formalized letter or document that can then go to peer-reviewed journals that demonstrate that it has gone through a review process as QI versus an IRB? Because in the nursing literature, that's what's being required for us when we submit a manuscript. We have to send that letter, either from the IRB or from a QI formalized.
Yeah, so this is part of the challenge, and it has to do, I think the challenge comes up with different journals. So one of the roles I do is I'm an associate editor for BMJ Quality and Safety. And what we require is a statement about how did you address this. And we accept a statement saying this work was deemed QI and was not formally reviewed by our IRB as per institutional policy. But we don't have any, we don't ask for a letter or anything like that as from the journal standpoint. But I know that different journals require different things, and so depending on where you usually submit articles, and if I don't know the nursing literature that well, but if they require letters, then it would be helpful for the institution to have a way to generate a letter saying it was determined to be QI and was okay. We were okay with it going forward. So that again, there's some ethical oversight of it, ethical oversight of the QI work.
So we've been really fortunate here recently within our nursing research department where our IRB has agreed to do a quick turnaround and take a look at some of our projects for us. So we're safe either way.
Mm-hmm.
However, we've also been told that, actually we aren't able to disseminate your information if you don't have that approval from IRB. So that depends upon the journal, actually. It's not necessarily the institution.
Right. So
So a lot of good QI work gets lost.
it can get lost. That's exactly. So a lot of good QI work can get lost between the institutional policies and the journal requirements, and there is often a mismatch between those. And what institutions, it's helpful for institutions to try to help match those policies so that their faculty can be successful in publishing for them, whether it's a letter as with the first question described, or whether it's some other mechanism. can be helpful. Some places have just sort of said, great, we're just going to send everything through the IRB, and we're going to put it under that umbrella. But many places have not, and many places have designed subcommittees or something else that kind of looks at it that can generate the official oversight. The challenge is still the people who put together projects and submit it. If it really has a component of research that it needs to go to the IRB, it might be expedited or exempt from review, but it still needs to have that IRB review if it has that research component. So, there's no easy answer. I'm not sure I answered your question, but it's actually, yeah.
You mentioned that some of this relates to patient safety and some of it doesn't. Do you understand the disconnection between how clinicians think about patient safety and how it's defined by funding agencies? Because when we do work with, say, you don't admit a patient that doesn't need to be admitted, if you stop doing the test, it doesn't need to be done. Clinicians think of that as patient safety.
Right.
But grant funders think of that in a completely different category.
Right. I think I'm going to repeat the question for the recording. So the question has to do with the difference between QI and patient safety and how it's often viewed differently from clinicians and from funding agencies and others. I think the strict definitions between patient safety and QI and the separation of them has not been helpful, because it puts people into certain categories. Like, well, I only deal with medical error, and I'm working to reduce medical error, so I'm a patient safety person. I don't do any of that QI stuff. But what it turns out is actually the implementation of things really is systems level work. You doing very similar. You doing a failure modes effect analysis, or our root cause analysis, is a patient safety tool, but it's very similar to that you learn to understand the system. And taking action on that, you're probably going to use quality improvement tools. So I see them as together, but yes, I would agree with you that I think there are folks who kind of, people end up kind of in their camp, and I think that it ends up hindering some of the learning and the growth that can happen across the different titles that exist. Any other questions? That's it. Thank you.